Evening, everybody. For those of you who are a little bit surprised, I am not Kathy Elf. I'm Emma Malcolm. I look after our fundraising and services at the Macular Society, and you've got me as host this evening. Kathy hasn't retired yet. We've still got her for a little bit longer. She was stuck in traffic and struggling to make the time. So you get me, Emma, tonight instead of Kathy. So tonight we're doing something a little bit different. We've got no slides tonight. It's your chance to ask questions. And we're welcoming an ophthalmologist and an optometrist, although at the moment we are slightly short of our ophthalmologist. And they're going to discuss in detail their roles, how they can help you both in the clinic and beyond. And we'll talk a bit about what's the difference. So I think because we have Yuan with us, we'll start with optometrist. So Yuan Gao is an optometrist at Imperial College Healthcare Trust. His journey began in 2016 when he moved to the UK to study optometry at Anglia Ruskin University, where he graduated. During his undergraduate studies, Yuan gained valuable experience working in opticians and volunteering at the Low Vision charity campsite. After completing his degree, he was eager to further his education and deepen his understanding of the field, and was accepted into the University College London Institute of Ophthalmology, oh, that's a mouthful, where he earned a master's degree in ophthalmology. During his time at UCL, Yuan developed a keen interest in ophthalmology and the role it plays in improving people's vision and quality of life. He served as the first president of the UCL Ophthalmology and Vision Science Society, and also started a podcast with the Institute to share his passion for knowledge and helping others. He is deeply passionate about the advanced practice in optometry, emphasizing the importance of education, primary eye care, and public eye health. So, hello, all 118 of you. So just a reminder, we have the chat function. We're not able to get the hand raising thing working at the moment. So please do put any questions that you have in the chat box. The chat box can be viewed by all of us. And so I'm going to kick off. We've got a few questions already. And actually, I think I'm going to start with the question. So, what is the difference, Yuan? And you know, when would I see you and when would I see an ophthalmologist? What is, explain.
Yes. So, hi everyone, and so good to see you again on this webinar. And that's actually a really good question because I do realize most of the time people don't know, they know ophthalmologists pretty well, but they don't know what is optometrist. So, ophthalmologist, I'll leave this part to Rashmi. I think she's in the crowd. We're trying to work out how to get her on the talk. But optometrists, we are. I always said optometrists are eye specialists. So we taking care of patients' eye from the primary care level most of the time. Sometimes we do work in the hospitals, just like myself. I work in the hospital full time. But for most of the optometrists are working in high street opticians, or they do different working environments. Like they can also be a domiciliary optometrist to go to do home visits, and also they can be a research optometrist working in universities.
I'm going to get you, Yuan, to sit a bit closer to your microphone because some people are saying it's a tiny little bit fuzzy. Just go back a second. And so this domiciliary word, what that means, doesn't it? That there are optometrists who go into care homes and stuff like that and would do your eye test with you in situ, so you don't have to go to an actual optician. That's what that means, isn't it?
Yes, yes. So there's a very small number of optometrists in the UK.
Yep.
If you go to different providers, they can send optometrists to your home and to do the eye test if needed. It is actually very good. But in general, optometrists, we are providing care at the primary care level. So if you do have any like discomfort of your eyes and you think something's going wrong, you can't see as well as before, and you see distortions, and you see whatever you feel is something wrong with your eye, theoretically you can see your optometrist first.
Yes.
But in some cases, like if you get really painful eyes, or if you hurt your eyes, Lots of patients will tend to go to the AMD. That's a good choice, but theoretically, you can see all your eye-related problems in your optician.
Yeah.
Even if it's urgent, they can direct you.
And presumably we'll have a range of people on the call tonight, some of whom will already have, it probably in the main have macular, but for most people, you will be the first port of call, won't you? There's something, I've noticed something weird with my eyes. I need to go and see an optician. Or will I have maybe gone to see my GP first and my GP might have said, go and see an optician?
Yes, that actually happens quite a lot, to be honest. And my patient, especially my friends, and they ask me, Yuan, I got this eye problem. Shall I see my GP first? I was like, please don't see your GP, because the GP will literally tell you to go to see your optician.
Okay.
Well, I mean, to see optometrist. We like using the word optometrist because I think it's like different between optometry and optician, but at the end, it's the same thing. So go to see optometrist if you do have any eye problems, and if they find anything needs to be sorted, let's say if you potentially need a surgery or any procedures, your optometrist will refer you in some area in England or in Scotland, different place, depends on where you are. They can either refer you directly to the hospital eye service, or they can refer you through your GP. So yes, see optometry first. It's a good decision if you have eye problems rather than seeing the GP.
And Joanne, presumably for those people with dry AMD, so they're not in secondary care, are they? Would your advice to all of them be to keep checking if anything changes with your eyesight, go back to your ophthalmologist, optometrist? See, even I'm getting confused.
So yes, in some cases we do see some of the patients with dry AMD in the hospital settings, but I think it's only when the dry AMD is at the very advanced stage. I do recommend people who has dry AMD or who even have early changes of macular problems, they should see your optometrist on a regular basis. Let's say it depends on how severe is the change. You should see your optometrist between a couple of months to 2 years. I really do not recommend anyone to don't see any eye care profession over 2 years. I think every year or every 2 years, even if you have any problems, it's good to see your optometrist. It's just like you seeing your dentist. People don't come to see optometrists that often.
Marvelous. Somebody's asked, is it that an optometrist focuses on the front of the eye and an ophthalmologist focus on the back of the eye? Is that or is that a rather yeah? Is that true?
I think that's not a correct statement. Optometry is looking, and optometrists and ophthalmologists, they look after patient different level of care. So we look after patients in the primary care. We do know everything about eyes. So we are more like a GP for the eye. So we see you, we figure out what is going on, which part needs a bit more care and what needs to be fixed. But when it comes to fixing it, is ophthalmologist's job.
Yes.
So we will refer this patient to a specialist clinic to do further investigations. If anything to be sorted, they will look after patient's eye in the secondary care.
For everyone who is listening, Yuan is in the clinic. So he's got some of the equipment behind him. So you're hearing a little bit of the clinic sounds. So apologies, I know you're sitting further forward. So somebody's asked here, so because we've still just got you, so they're looking to buy prescription sunglasses. How can they be sure that they're UV protected and not just tinted? And do all optometrists provide UV safe sunglasses as standard?
This is a very good question, actually. So what is the best way to find out is to have your eye test first, and afterwards your optometrist will send you to see another profession, which is dispensing optician. Dispensing optician, they are experts in different glazing and different types of glasses. So you will be able to have a chat before you actually get your pair of spectacles or sunglasses with the dispensing optician to discuss about different coating. So I do advise, if you do have any questions about your lenses, or you have any questions about the fitting of the glasses, you have a chat with the dispensing optician.
Oh, yay. We have our second speaker. Marvelous. Everybody, we have our Oh, see now I'm getting
Rashmi.
confused. We have our ophthalmologist now, Rashmi. So, Rashmi, yay! I'm so sorry you've had so many problems joining.
Not at all, not at all. That's what technology does, and that's absolutely accepted. I'm
Yes.
glad to be here, and it's very interesting to look at the questions.
There's so many questions. And yes, as Bernie's pointed out, it's not just people with AMD on the call. There's people with DMO. There's every single macular condition. So Rashmi, how does what you do differ to what Yuan does? Because you're both in, so I suppose that's the complication, isn't it? That you're both in the hospital, whereas my experience with ophthalmologists is in a well-known high street store. So what's the difference between the two of you and what you are both able to do?
Excellent question. Traditionally, an optician was somebody who would dispense glasses.
Yeah. So salespeople, effectively.
Exactly.
Sorry, opticians.
Because the major part of the treatment was correcting the refractive error of the eye to allow you to see clearly. And this was done with glasses, lenses, and magnifiers.
Yeah.
But as experience grew in this field for opticians, they started recognizing the different eye conditions. They knew to give short-sighted people a certain kind of glasses. They also got experienced in what these people come with, what problems they come with. And if you think about it, the eye is a special sense. And so to examine the eye, you need a special equipment, like the slit lamp. So the opticians got trained on a specialist equipment to examine a niche thing like the eye. And what then we eventually, as ophthalmologists who are basically eye doctors, realized that they were more an asset than a physician or a GP who was a doctor but did not know how to use this equipment.
Yeah.
That's how the whole optometry progressed from just dispensing glasses to actually knowing about the eye. And now it has gone to an extent that we've divested a lot of simplistic care to the opticians who can then take it to grassroots levels into the community. So it's not, loosely said, if you have an eye problem, going to your optician enables you the access to the machine, which can look at the back of the eye, the experience to do so, rather than going to the GP, A&E, or your physicians. And then we get these optometrists into the hospitals, and they work with us as associates in the clinic. And so we teach them how to recognize the moderate to high risk conditions as well, and then send them to us to treat it. So an optician specializes in dispensing glasses and then knows more about the eye, but is not a doctor. An ophthalmologist is a doctor who knows everything about the body and then specializes into the eye, treatments of the eye, and surgery for the eye. So that's the basic difference.
Yeah, it's that getting it down, isn't it? I'm more and more specialist. So we've got so many questions. So I'm going to try and go back to the beginning, and I'm basically just going to fling stuff at you guys. Feel free to both answer, one or other of you answer, or to say, actually, that's something that I don't know the answer to. So I'm going to start at the beginning. So Edward says, sometimes I meet macular disease sufferers where it seems difficult for optometrists to differentiate between dry and wet macular disease. Why could that be?
Do you want to take that, Yuan, first, and then I follow? What's your perspective?
I think it really depends on where the optometrist see this patient, because myself, I work in a community in the past. In some of the community practices, they do have limited access to some highly specialized machines. So what I think is that if they've seen optometry. So optometrists see a patient who's quite finding it difficult to differentiate dry and wet. It's because either that they can't see it very clearly, or the machine is not, very advanced to pick that things up. But being honest, from my own experience, differentiate from dry and wet is not a very difficult thing. But I think the primary care optometrists, they will refer you if they are not sure about dry and wet, because wet is actually considered as a eye emergency. So I do believe optometrists in the UK, if they have doubts, they will not just let you go. They will guide you to the hospital emergency, even it's dry and they're not sure. So
and presumably OCT scanners have made it easier to spot and differentiate, even though you have to pay for them.
Yes, of course. The good thing is that most of the UK practice has adopted OCT scans, so differentiating dry and wet AMD is much easier nowadays in high street optician.
Yeah.
So what I would like to add to that is dry AMD is just wear and tear at the back of the eye. When the wear and tear goes to an extent that the differentiation between your nerve layer and blood vessel layer falls off, then things bleed or leak into the back of the eye. And that's what we call as a wet change. Now, the eye is a small structure, and further, the tissues are even more minute. So when we examine your eye on the machine, we can, if the bleed is big enough, we can see it at the back of the eye, and an optom or a doctor can diagnose this as wet. But when it's within the minute tissues, then you kind of need a section of the eye to be seen under a microscope. Now, the same thing is done with the help of light by the OCT machine, where the light penetrates into the layers of the eye and sees if things have leaked or bled into it. And that is also the scan which guides us to give you injections, how many and how often.
Marvelous. I'm going to combine a couple of questions here. So there's somebody asking a bit about diet and lifestyle, and somebody else about ARIDS too. So diet and lifestyle, we recommend eat the rainbow, and there's evidence, isn't there, around the ARIDS too, vitamins. When you're searching for them, you just need to search for ones that say they're ARIDS. Presumably it's safe to just keep taking those. Can you just take the ARIDS forever?
So the ARIDS 1 formula had certain outliers. And when you had respiratory problems and things like that, you couldn't take a bit of zinc and things. And they were, as I said, they were outliers. But with ARIDS 2, yes, you can. There is a caveat there, because
it's always a caveat, isn't there?
There's always a caveat. The supplements help to slow down the progression, provided you are of the right genetic type. Meaning that if you have a gene that is timed for you to get into the wet range, you will.
And presumably you're not going to know that either, are you? So,
no, you're not.
But
no, you're not.
Presumably, though, taking them isn't going to harm you.
Very, very unlikely.
Yeah. So, and for the person that's asked about MacuShield and Gold, you're just interested in ARIDS too. I don't think it really matters, does it, which brand you take? Just make sure they are the ARIDS too, because we know that there's scientific evidence behind those, isn't there?
Yes. So a formula which has copper, zinc, lutein, and zeaxanthin, but no beta carotenes, which was the previous one, works.
Okay. A question here. Someone says, I have MMD, myopic macular, and they're saying, is it significantly different in terms of care and treatment compared to AMD? So would they have a different treatment having that versus AMD?
What was the condition's name? I think you just touched on.
I want to say myopic macular.
MMD.
There you go.
Yes. Do you want me to take that, Yuan?
Yeah, I think Rashmi, you're the expert in this, so I'll let you.
No worries. Wet macular degeneration is wear and tear. Myopic macular degeneration is because myopia is short sight. It means that your eyeball is big, so all the layers of the eye don't catch up with each other. So the basic reason of the two conditions are different. They do the same thing in the end. They cause a membrane which bleeds or leaks. But with age-related macular degeneration, wet, this is an ongoing procedure, ongoing process. Whereas with myopic degeneration, it's just a localized defect. So the membrane in a wet age-related macular degeneration continues to spew fluid, needs treatment for a couple of years, whereas with myopic, it's difficult to diagnose. It's on the edge of the scar, generally needs a specialized ophthalmologist to diagnose, but would need less injections.
Which is probably a relief, isn't it? Because we know lots of people really don't like injections. There's a question here about eye pressure, Yuan. So I don't know about everyone else. I have mine checked every time I go. So the question from Joan is, would they turn you away after a few visits if you're going several times in a year? Or, you know, is it safe to have the puff test, the eye pressure test frequently? Would you need to have it frequently?
So I do advise every time they go to see an optician, they get eye pressure checked, because when we're talking about eye pressure, I think the main concern is the pressure being high. That could potentially cause some glaucomatous damage for the back of the eye. So every time you go to see an optician, no matter where you see them in a high street or independent practice, my feeling is most of the time they will measure eye pressure. But there's different ways to measure eye pressure. So the most common one is the air puff, which everyone absolutely hates it. And
you just want to blink.
They always feel like there's a gun pointing at their eyes. It's an air puff. So I'm not a big fan of that either, because the gold standard in measuring of pressure, if we do need to make any decisions of treating eye pressure, is the Goldman tonometer, but unfortunately, I don't think it's very commonly to be used in the high street practice.
It's probably expensive, isn't it? Which is why, if they do introduce it, presumably they'll charge you extra for it.
So I think that's the first point. The second point is that most of the opticians, they have their appointment booked really tightly, so they don't physically have the time to do that test for their patient. What they would do is if they find out the eye pressure is slightly on the borderline, or if it's a high, they would directly refer to the hospital eye service. But I think for the best practice, every optometrist should refer with the Goldman tonometer before they refer it. But the reality is they cannot do it now. But hopefully in the next 5 to 10 years, for a certain time, that will be changed.
Marvelous. So you guys touched on this earlier. So the difference between an ophthalmic optometrist and a dispensing optometrist, because they are different, aren't they?
Yes. Yes.
Well, when we're talking about optometrists' role in the UK, Rashmi, I have to say that we don't have a dispensing optometrist. I think all the optometrists nowadays, they are qualified to look after patients' prescription. Of course, this is a big part for glasses and also contact lenses, but also they will have the basic knowledge to spot the eye problem. So there's not such a dispensing optometrist only for giving glasses, or a ophthalmic optometrist only looking after the eye care. So theoretically, every optometrist here who works in the UK who has a GOC registration will be able to check your eyes on both dispensing point of view and also that eye health care point of view. But also there's lots of highly specialized upskilled optometrists who work in a hospital they really specialize in certain ophthalmic conditions, and they work very closely with a consultant to co-manage the condition. But like Rashmi said, optometrists in the UK are not considered as a doctor, but you will see a specialist in the hospital as optometrists as well if you go into some specialist clinic.
Yeah, cool. So Hillary's asked, she has Stargardt, and she's asking, is there a genetic test? And if there is, how does she need to get a referral in order to be checked for that? And how does she do that?
So Stargardt's is a spectrum, and I don't know at what age she got it, but generally it's in the second decade, or later on you get in the 4th or 6th decade. And the gene is ABCA4. You have genetic testing, you've got electrodiagnostic testing for this, both. And then you get genetic counseling and work counseling, as well as to know what's if it's inherited and in what proportion. The best thing would be to get a referral via your GP, either to us, the Western Eye Hospital, or to Moorfields Eye Hospital. And then we will do an OCT scan with a fundus autofluorescence, a specialized test, to see how advanced your Stargardt's is. And then we enroll you into a genetic clinic, which deals with the testing and knowing the prognosis, as well as inheritance in this condition.
Yeah, marvelous. Patricia has said, I'm registered severely sight impaired. Is there any point in me seeing an optician? I'm under regular care with the hospital physicians, and I'm going to attempt to read what your condition is. It's called serpiginous choroideus uvitreous and bilateral glaucoma. Wait a minute, that's a mouthful. So yeah, is it any point, Patricia, going to an optician if she's under the hospital for her other...
Yeah, I'll answer the first part of the
Go on.
question. I think the second part of the question is for Rashmi to talk about that condition a bit more. So I think there is a point, because I'm not sure if you're using the low vision aid at this moment. Optometrists are specialized in low vision aids. So if you do need any aids to potentially to let you, you know, if you have some sort of the vision left a little bit, they can help you with, let you see slightly better, maybe help you with like day-to-day activities as well. And also optometrists can get in touch, let you to get in touch with other charities like Macular Society, also the RNIB, and will get you a lot of help if you find a good optometrist to take care of you if you leave with low vision. I think there is a point to have a good relationship with the optometrist.
Yes, a lot of that signposting that's so important, because we know,
yes,
don't we, lots of patients just don't get told that there is places that they could come for support, and that there's all the low vision aids and technological solutions that can help you in your daily living. So yes, it's definitely worth going, if nothing else, to then get told lots of hints and tips about things you can do to live more easily with your sight loss.
Yeah, that's correct. Yes.
Yeah. Rashmi, I didn't explain this very well. So can you tell me, what does ARIDS stand for? There's some people on the call who haven't heard of it. So can you remember what that stands for? It was a big research study, wasn't it? Looking at the different components that you'd put in a supplement that weren't basically not going to damage the eye, weren't they? Is that right?
So I'll tell you the background. I mean, you can Google it, what ARIDS stands for, but
and is it AREDS, isn't it?
AERDS. AERDS. And there were two massive trials. So I'll tell you the background and why, so that you get the gist of it. We've traditionally always looked into what causes cataracts and what causes wear and tear at the molecular level. And what we found, that there's a breaking of a barrier between the blood layer of the eye and the neural layer of the eye, which is the wear and tear. And so when we concentrated on one particular part and we thought, why is there breaking at the cellular level? There is because of depletion of a very important yellow pigment called as lutein and zeaxanthin. And then we further, when we did microscopic studies on mitochondria, which are the cells where all of this happens, I know it's a medical jargon, but what we found that for the lutein and zeaxanthin to do its work and stop their depletion, tiny micronutrients, zinc and copper and beta carotene were essential. And so then there started a race to develop a product which had all of this, and the best way that could stop the depletion of lutein and zeaxanthin. With the ARIDS first, which was a massive trial, we found that if you take these supplements, then the chance of getting advanced macular degeneration in a small subset of people who have already moderate macular degeneration or advanced degeneration in one eye was reduced by 25%.
Gosh, so that's significant, isn't it?
That's significant, but it also had side effects. So then, and it was patchy. So then they launched another major trial, which was the ARIDS 2, from which were born the Macugen, the MacuShield and everything, where they removed the components which were causing side effects, or which would combine and cause precipitation of toxicities, and came up with a formula. There's another trial after that, which is called as the prevision trial, because as I said, it slows down the progression, doesn't cure, so not everybody believes it. And the results are patchy. So the explanation on the third trial was that, yes, it slows down in 25%, but those 25% which do have weak genes for macular degeneration, because it also has a genetic, if not inherited component.
Cool, thank you. And then, so we know a lot of people who are having injections will be seeing the nurses and not the ophthalmologists. Should I as a patient be worried about that? There's Mary here has said in 6 years she's only seen the ophthalmologist twice. She sees the nurse regularly for her injections. So would that concern you, Rashmi, that she's only seen the ophthalmologist twice in 6 years?
I think that would be unheard of. So that shouldn't be the case. Okay. Nurse injectors have hugely helped deliver because of capacity issues. And the actual injection, mind you, is a technique, and people can be trained. However, to know whether you need the injections or you do not need the injections, you need a doctor with experience. So it's very unlikely that you would have not seen an ophthalmologist. It's very likely that you would have not had an ophthalmologist who gave you an injection. Now, for that, you shouldn't be worried, because injections are very safe and easy technique, and I train nurses in giving injections, and that's very rigorous. There are appraisals, they have to do a certain number, they're supervised, so nobody should be worried about that. But I think they would have regular appointments, if not at the same at every appointment, every couple of appointments, they would have an ophthalmologist.
Yeah, so I think if we would say, if we were you, we would ring them to say, I think it's about time I saw the ophthalmologist, just to check that everything is okay.
Yeah, and you can ask that at every visit.
Yeah. I'm going to ask you a really difficult question now that Gillian has asked about the statistics on the risk of inheriting AMD. So we know, don't we, that there is an element of genetics in age-related macular degeneration. Do we know what the actual risk is? So say I had it, what the risk would be for my child or my grandchild? Are we able to quantify that?
So there are certain conditions like Stargardt's, ABCA4, where there's an autosomal dominant or autosomal recessive inheritance, which means depending on how much you take of each parent in each chromosome, and then you can predict 1 in 4, 1 in 2, depending on that. So half of your children will get half of it.
Okay.
Most of the conditions have variable penetrance, and AMD is on the lower spectrum of variable penetrance. So you cannot quantify the long and short of it is you cannot quantify it. However, when you study a pattern of progression, you would know. So you can say that, yes, my mom went from moderate AMD to advanced wet AMD in 2 years. Something similar will happen to me. However, if she was a smoker and you are not, things change.
Yes. So presumably that's why there isn't currently a genetic test, is there, for AMD?
No.
Because whilst there's the genetic element, there's also the environmental, isn't there? So it's not an exact science, unfortunately, at the moment. So if that changes, and obviously we're funding research all the time, we will let everyone know. But I think the thing to say is, eat the rainbow, don't smoke. Yes, there's probably an element of genetic risk, but you don't lose sleep over it, because we can't quantify it at the moment.
Absolutely right.
Marvelous. Oh, phew. Bernie has asked. So Bernie says, I have oh God, see, this is where I was getting my tongue twisted. Pharmacomorphic glaucoma. Can that be helped with any foods? And Bernie also has DMO and PSC and nuclear cataracts. So yeah, are there any foods that would be helpful?
So a phacomorphic glaucoma is due to the lens. And the treatment of phacomorphic glaucoma would be removing the lens or the cataract. It can either be because of the size of the lens or leakage of the lens. So I don't think all of these can coexist. But if that's the condition, that's the solution. You don't even wait for food. For diabetes, yes. a diabetic control definitely. It reduces the chance of retinopathy by 50%, nephropathy by 45%. So controlling your blood sugar levels, controlling your cholesterol and your blood pressure, easier said than done.
Yes. Oh God, yes. Don't we know? We have a question here that says, why do optometrists not do applanation
Tonometry.
thank you. Because and apparently that's usually more reliable than the air puff. So come on, why is it a cost thing?
No.
Well, it's a good point actually. I think it's mainly because that most of the high street opticians that you would see on the street, they are booking patients in a very short time, and it's not legally required that you have to do the Goldman tonometer every time for the patient. So that's why they decided not to do it. But again, as I said, for good practice, I think every optometrist should do it if they suspect there's an eye pressure problem. We said the applanation tonometers is more reliable. I think when we're talking about reliability, I would say I always talk to my patient that the Goldman tonometer is the gold standard, but any other tonometer we'll still use it. I won't call it unreliable. I'll just call the applanation the gold standard. It's the pressure that we're going to use if we want to treat the eye pressure in the clinic. So that's the answer to this question. They are not illegally required, but I think they should do it.
Can I add something to it, Yuan? Because this has been asked the second or third time.
Yeah.
Applanation tonometry essentially involves a machine touching the eye, the front cornea. That can give corneal abrasions, that can give infections. So it is a process that needs to be appraised. So when an optom is in the clinic, in the hospital, we can do appraisals if there are complications because of this, or to know the technique of it. In the community, that appraisal, that governance is not there. So it is a skill technique with potential complications that cannot be let loose for patient safety in the community, one. And two, the Goldman applanation tonometer needs to be scaled, because otherwise it can give wrong readings. So there is a way in which you scale it to the machine, which again is something that's routinely done in hospitals. So it depends, both patient safety and instrument accuracy is guaranteed in the hospitals, not in community. That's why it's not common in the community.
Yes, we need the technology to advance a bit more, don't we? We've had a few questions about red light therapy and whether or not it's beneficial to preserve retinal health.
Do you want to take that, Yuan? And then I'll follow.
I think Rashmi, you can take this one. I have no opinion on red light myself, to be honest.
So there are many alternative treatments: red light, magnets, UV light, lasers. Again, this is alternative medicine or alternative science. There are countries in which it is hugely acclaimed and accepted. All I can say is there are no evidence-based trials for it. We don't know of cases which are harmed by it. And there have always been these walks of life, take it Ayurveda or homeopathy, and they possibly do have their own evidence base. However, from the treatments that we administer, I don't think we particularly have the evidence base to say that there is results from it.
Rashmi, is that a bit like the coloured lenses that they work for some people, don't they? They don't work for others, and there's very little scientific evidence about them. But actually, if it works for you, go for it. It's not going to do any harm.
True.
Marvelous. Thanks. Question about exudates in the eye. What are they, and what causes them?
Shall I take that as well?
I can briefly touch that. I think exudates, I think in the most commonly that is found in if you go to a diabetic clinic, or if you have maybe slightly different condition that you optometrist or your eye doctor will tell you that there's some exudates. So it is, I would say, Rashmi, correct me if I'm wrong about this. I think the type of fluid, and it can accumulate in a different part of the body, but in the eye, it can accumulate on the back of the eye. So if you see exudates, that means that there's something going wrong with your eyes and needs to be taken care of, especially if you have diabetes. I think that's one of the signs for a what we call retinopathy, is because that your eye is affected by your diabetes at this moment if you see exudates.
Yeah. So the eye is not meant to blister or leak at the back of the eye, because every point at the back of the eye means a point of vision in your visual field. Now, if things start leaking or blistering at the back of the eye, as they do everywhere else in the body, which is what diabetes or blood pressure or some of the inflammation conditions do, then what happens is the fluid accumulates, separates the cells in the eye. Whenever fluid accumulates, it's like a choked sink. Things start precipitating, and those precipitates from your plasma or your blood in the retinal layers are known as exudates. So firstly, they indicate an illness, a systemic illness or an inflammation. And secondly, they are detrimental to vision. So what do we then do? So when we see exudation, we either laser around it so that the fluid and the exudates are absorbed, or if it's because of inflammation and things underneath are leaky in the eye, we prescribe medication like steroids to take away the exudation. Very rarely, in a condition called as central serous retinopathy, where there is extensive leakage and exudation, we do a cold laser called as photodynamic therapy. So those are the treatments and causes for exudates.
Marvelous. We talk a lot to people who are having cataracts removed and who also have AMD, dry or wet. So is there additional risk in having a cataract removed if you've got any form of AMD? Would you worry?
Shall I take that?
Yeah, this question is for experienced surgeons, so it's for you, actually.
So the first thing when we consent a patient with cataracts who have AMD is the macular degeneration reduces the potential of vision after cataract surgery. Because cataract is a curtain. You remove it, you put a plastic lens in, everything is restored. Retina is the film of your camera. We can't restore it. So the damage done by the macular degeneration cannot be reversed by cataract surgery. Having said that, cataract surgery gives you peripheral vision, so your vision would get better anyway. I've done cataracts for a long time and many, many thousands. And traditionally, we used to believe that when we did cataract surgery, the chance of wet macular degeneration getting worse was 50%. And I had experienced this as well. So somehow the cataract gave a protection. You remove the cataract and things bled at the back of the eye. But since the injection era, which has been 2 decades now, starting with Lucentis, we don't see this. So we're very confident in doing the cataracts and giving the injection at the same time. So if you come to my list, you would have a phaco-cataract extraction and an Eylea injection or a faricimab injection done after the cataract surgery. So one should not be apprehensive of cataracts. They will make your vision better if you have AMD, but at the same time shouldn't expect 20/20 vision just because of the cataracts.
Marvelous, thank you. Annie has asked, are there any injections for younger boys with XLRS in order to maintain the existing good eyesight and stop it deteriorating?
XLRS is a very, very specific condition, and these are cystic spaces at the back. So they're just spaces and cysts. Injections mainly work on fluid. And while we've empirically treated XLRS with Avastin and injections like that, because the basis of the condition is not VEGF or overdrive of VEGF, and anti-VEGF doesn't work.
Yes.
It unfortunately isn't something where gene therapy or injections like Luxturna, where we put in a vector in the retina to settle the cysts, fall in the same domain, but that could be the thought process going forward. Because you get rid of the cyst, but at the same time, the layer under the cyst, which is meant to catch the light and help your brain see, regenerates. That might be something we look in 10 to 20 years. So never say never, hope something will come up.
Jonas asked, do injections raise eye pressure? That's a great question.
Yeah.
Yeah, I think that do depends. I think Rashmi, again, if I'm wrong, correct me, because in my opinion, eye pressure should be always monitored after injections, and also if you're getting a steroid injection, that's especially needs to be looked after, because the steroid injection could, if you respond to the steroid, that your eye pressure will be high, and that could potentially cause some sort of damage to the back of the eye if you receive regular injections. So I think the answer is you need to monitor eye pressure ideally after injections.
Yeah, but it shouldn't raise the eye pressure just having injections, should it?
It will.
It will.
It will. So the question that we ask when we recruit a retinal fellow, who's our doctor, is what will you do? At an interview, that's always my question. What will you do when the pressure rises? And the reason for that is because the eye is a closed volume. And the fluid at the back of the eye...
Does it think it's a foreign body, so it wants to...
It's 4 cc. The volume of the fluid is 4 cc. You're injecting a bit more volume into it. And so depending on the size of the eye, there is a chance of a spike. It also depends on how much you inject, whether more air goes in, and the technique. But the commonest complication is a spike in the pressure, which gives intense pain. And that's why we train nurses and doctors to relieve it. So it can be treated. It's not dangerous, but it is a known complication.
Marvelous. And then Margaret says, after injections for AMD, there are black spots in the eye. Is that normal?
Because we can't remove the air from the dead air space in the syringe, the black particles are mainly air bubbles, and they get absorbed in the next 24 to 48 hours. So the whole race is, because we always say who's the best injector, is the way you inject, that the air bubbles go into the periphery and are not noticed, or the way you remove the dead space in the syringe.
I love that. So you know if you've got a good injector if you're not getting any black spots. There you go. That's a good test for the next time everyone goes and gets their injections. If you don't see black spots, you know you've got a master injector. I love that. Judith said
that you see that because of the injection gone in. So
yeah.
Perhaps the injection gone in.
I love that. Judith says she has dry AMD and had cysts in both eyes. Can any damage be done by these?
The cysts, in what context? Were they at the back of the eye?
I don't know, Judith. We'll need you to tell us where they were, I think.
If they were at the back of the eye, along with the dry AMD, it slightly goes against the definition of dry AMD. But if they're just cysts, and that's why somebody is not injecting you, then there's no damage done. Somebody's just keeping an eye on the cysts.
Marvelous, marvelous. And then we had a question in advance that said, I have macular degeneration in my right eye. I would like to know if this is connected to feeling disorientated from time to time and sometimes feeling unsteady on my feet.
That's a very good question. We generally attribute balance to vision because that's where we feel the dizziness and the giddiness. Unfortunately, it's the same age when the macular degeneration sets in as your inner ear problems set in. So when it is your balance, especially when you close your eyes and put your hands forward and you still see, it's always the inner ear. So I always advise if you have balance problems to my patients, you go to the optom and look for your degeneration. You go to the GP and say, give me a Stugeron. I'm at that point where I'm getting balance problems. And it's generally confused both by the GPs, both in A&E. Everybody attributes balance to eyes. Balance is ears.
There you go. And then there's a question here that we get a lot. So Robert says, my mum has started having injections for wet AMD, but there have been very long delays between injections, 8 weeks instead of 4 during the initial phase and 16 weeks instead of 8 weeks after. Is this a common experience at the moment, and what are the risks?
So again, it's a pursuit, it's a constant race to find injections which will have a shelf life which will work longer than 4 weeks. It is not rationing. Increased injections will cause atrophy at the back of the eye and actually damage. So the further the injection interval without symptoms, it's actually better. And you're getting your injections, which are meant to be given every 3 months or 4 months. So you have to be rest assured about that. And that's called as treat and extend the interval, because injections are not always good. One. And the second thing I must say is there shouldn't be an apprehension because of the delay, because especially COVID has taught us that we did not need to inject so frequently.
Yes. Yeah, we have a lot of clinics have realised, haven't they can go longer. Whilst we know there are some clinics where the delays there's a real workforce shortage, particularly in ophthalmology, isn't there? But that actually we've seen that there are some people who are able to go longer in between injections and not have a negative and anything negative off the back of that. It's being able to work out which group of people are which, isn't it? That's the challenge. And of course, we want to get to a point, don't we, where we have new things that you can inject that would last even longer. So potentially you would go maybe twice a year. So, because people don't like injections, do they? So Derek says, we've got just time for these last two, I think. Does Eylea HD cause extra pressure in the eye?
Not really. It depends on how much volume you inject. Ilea's come up with something which is double volume, which was, I don't know why not the logic. It seems too simplistic, but no. And it can be monitored safely by putting in iopidine drops to lower the pressure and do some other maneuvers.
Marvelous. And then I think this is our final question. Graham says, I have wet AMD in my right eye and dry AMD in my left eye, which we hear a lot, don't we? Will the left eye also go wet?
So the chances are 30% in about 5 years. However, the chances are influenced by whether you continue or stop smoking if you've never smoked, control your blood sugar levels, control your cholesterol levels, and eat lots of green vegetables.
Yeah.
And also, if you do realize any sudden distortions in your vision, you need to see your eye care specialist as soon as you can, because that could be an indication that the other eye is turning from dry to wet. When you see those distortions in a very short time, which is very good to keep something called Amsler grade, I suppose.
Yes. Well, I was going to say, Yuan, so presumably going back to our question of earlier from the lady saying, is it worth going to the optician? It's worth going to the optician, isn't it, to get an Amsler grid? And if you do nothing else, do the whole blinking to check that there's no difference between your left and right, or if there is, it's not getting any worse.
Yeah, an easier way is to cover one eye to look at door frame. If the door frame is straight, if the door frame is straight, there's no distortions, that'd be great. And if there's some sudden distortions, that is the time you need to see someone. I actually had a patient who is a professor in virology today, and he said he realized that there was a sudden distortion because he had an 8 microscope on his bookshelf, and bookshelf is actually not straight, and he was a bit worried about the distortion, but it actually came out that microscope is too heavy. But this is
the
how
shelf was bending rather than it being a distortion on his sight.
But this is how he measured, how he monitored himself for distortions. But I think the best way is to get an Amsler chart. Yeah. I do think there's an Amsler chart that you can download from the Macular Society website, do you?
Yes, I think we have an Amsler grid on the website. But yeah, I think a lot of opticians will give you one as well. Yes. So if you do nothing else, have an Amsler grid up somewhere and you alternate your eyes and check. Or if you've got stripy wallpaper or anything that has straight lines, check it. And if it starts to go wonky, then yeah, go as an emergency.
Yes.
Marvelous, marvelous. And Barbara said, yes, they're eating walnuts is also very good for you, isn't it? It's all the same advice for everything, isn't it? The Mediterranean diet, limit your ultra processed, eat the rainbow, don't smoke, will help you pretty much with everything, I think. Although
I think
sometimes,
smoking is the big thing.
smoking's a big, it is the big. Oh, both, thank you so much, both of you. This was so fascinating. I've learnt loads, although clearly not how to pronounce some things. So apologies for some of my mispronunciation. Next month, we're going to be discussing the Valeda light therapy, and Kathy will be back. So in the meantime, if you need anything at all, do go to our website, macularsociety.org. And if you want to talk to somebody, you can call the helpline on 0300 30 30 111. Rashmi and Yuan, thank you so much for your time this evening. And we hope everybody found that useful and informative. Take it easy, gang.
Thank you so much. I would just like to add to all the participants, the Royal College guidelines say that you can have a direct access to a retinal specialist. So you can email them, because I saw lots of questions which I was itching to answer, but time permits. So feel free to contact us with your questions. You can. And opticians are the way to go, because if you go to GPs, they won't be able to diagnose opticians well. So absolutely feel free to contact us.
Marvelous. Thank you both, and have a good evening, everybody.
And you, thank you so much.